lecture series, and it is the orbit part 8, and it is going to be the last part of this chapter. So let's get started. So in this part we are going to discuss about the metastatic tumor. So what are metastatic tumors? So basically these are the orbital tumors which are secondary to some other metastasis from some other organ. Like for example, the primary lesion is in the lung, and um, and now it has invaded the orbit as well, so it is called the metastatic tumors. So adult metastatic tumors, orbital metastases are an infrequent cause of proptosis and are much less common than metastasis to the choroid. If the orbit is the site of initial manifestation of the tumor, the ophthalmologist may be the first specialist to see the patient. In approximate order of frequency, the most common primary sites are breast, up to 70%, bronchus, prostate, skin, melanoma, and gastrointestinal tract and kidney. So one thing you must remember that this breast cancer are like most common associated with the metastatic tumor to the orbit, and usually the choroid is the more uh, is more prevalent for the metastasis, but orbit can involved as well. So how will you diagnose? There will be signs associated with range of the tumor that can spread to the orbit. Presentation can take a variety of the forms. So whenever there is a mass in a case of orbit, there will be some kind of proptosis, there can be some kind of dystopia, there can be some kinds of ophthalmoplegia as well. Dystopia and proptosis are the most common features. Infiltration of the orbital tissue, characterized by ptosis, diplopia, brawny, indurated periorbital skin, and firm orbit with resistance to manual retropulsion of the globe. So when you try to retropulse the globe, it will have a restriction. Anophthalmos with cirrhosis tumor, chronic inflammation primarily with the cranial nerve involvement, 2, 3, 4, 5, 6, and only mild proptosis with orbit apex lesion. So if the orbit apex is also involved, there can be the cranial nerve involvement as well. So what will be the investigation? Imaging, CT and MRI typically show a non-encapsulated mass. Fine needle biopsy is useful for the histological confirmation. If this fail, open biopsy may be required. A search for the primary must be carried out if the patient was not previously known to have a cancer. So in any case of the cancer, you must do first the imaging as well as the biopsy as well. So treatment is aimed at preserving vision and relieving pain because most patients die within the year. Average 4-month radiotherapy is the mainstay of the local treatment, but systemic therapy may also be of a benefit. Surgical excision of the focus is occasionally carried out. Orbital excision is usually only performed if other modalities fail to control the intolerable symptoms. So because these are metastatic disease and the tumor has spread already to the most part of the body, so you try to do the radiotherapy to relieve the symptoms. But sometimes if the symptoms are intolerable, you can do orbital excision as well. So this is a 4.45 figure is showing a metastatic renal carcinoma, A is showing proptosis, and B is showing the axial, CT showing a non-encapsulated retrobulbar mass. Next is a childhood metastatic tumor, very common, is a neuroblastoma. Neuroblastoma is one of the most common childhood malignancies. It arises from the neural crust derived tissue of the sympathetic nervous system, most commonly in the abdomen. Presentation is usually in the early childhood. In almost half of the cases, the tumor is disseminated at diagnosis when it carries a very poor prognosis. Orbital metastasis may be bilateral and typically present with the abrupt onset of proptosis accompanied by the superior orbital mass and a lead ecchymosis. Very important, lead ecchymosis is associated with the neuroblastoma in the childhood. Basically, these are the neural crust cell that have been proliferating, and these are most commonly located in the abdomen, and when it metastases to liver, to the orbit, it causes the proptosis, mass, and lead ecchymosis. So we can see figure 4.5 4-6, A is showing neuroblastoma, A is showing axial CT showing a tumor adjacent to kidney, B is showing bilateral orbital metastasis, and you can see that there is a lid ecchymosis as well. Next is the myeloid sarcoma. Myeloid sarcoma granulocytic sarcoma is a solid tumor composed of malignant cells of a myeloid region. Because the tumor may exhibit a characteristic green color, it was formerly referred as coloroma. Myeloid sarcoma may occur as a manifestation of the unestablished myeloid leukemia, or it may precede the disease. Orbital involvement usually present at the age about 7 years with the rapid onset of proptosis, sometimes bilateral, and can be associated with ecchymosis and lid edema. When orbital involvement precedes systemic leukemia, the diagnosis may be difficult. So basically, it occur in association with the systemic myeloid leukemia, and the symptoms are the same, that patient can present with proptosis, sometimes with ecchymosis and lid edema as well. So Langerhans cell histiocytosis. Langerhans cell histiocytosis is a rare group of disorder due to the clonal proliferation of the histiocytes. Presentation ranges from the localized disease, usually with the bony destruction, eosinophilic granuloma through multifocal bone involvement, to a fulminant systemic disease. Soft tissue are less commonly involved, but cutaneous and visceral lesion may occur. Orbital involvement consists of a unilateral or bilateral osteocytic lesion and soft tissue involvement, typically in the supratemporal quadrant. Patients with the solitary lesion tend to have a more benign case and respond well to the treatment with local curettage and intralesional steroid injection or radiotherapy. Systemic disease has a worse prognosis. So basically, the Langerhans histiocytosis is the proliferation of the histiocyte. It causes the bony destruction. It can be mild to severe, and in the orbit it also causes the osteolytic lesion, and especially in the supratemporal quadrant. And treatment is with the curettage and the steroid injection or radiotherapy. So this is the Langerhans cell histiocytes. Next is the orbital invasion from the adjacent structure. For example, if a patient is having a tumor of the nose or maxilla or any other adjacent structure and it is invading the orbit, this is called the orbital invasion. Sinus tumors. Malignant tumor of the paranasal sinuses, although rare, may invade the orbit and carry a poor prognosis unless diagnosed early. It is therefore important to be aware of both their otorhinolaryngological and ophthalmic feature. Number one is the most common is a maxillary tumor. Maxillary carcinoma. Maxillary carcinoma is by far the most common sinus tumor to invade the orbit. Otorhinolaryngological manifestation include facial pain and swelling, epistaxis, and nasal discharge. So a patient who is having a maxillary carcinoma will have a nasal bleeding, will have a pain, facial pain, and will have a discharge. Ophthalmic features include upward dystopia, diplopia, and epiphora. So you know that mass is inferior to the eye, so when it's invading the orbit, it will cause the upward dystopia, and with the dystopia there will be the diplopia as well. With the ethmoidal carcinoma, you know that ethmoidal carcinoma is present in the medial side of the nose, so when it invades the orbit, it will cause the lateral dystopia. Nasopharyngeal carcinoma may spread to the orbit through the inferior orbital fissure. Proptosis is a late finding. Next is a bony invasion. Intracranial meningioma arising from the sphenoid ridge may invade the orbit by direct spread and cause proptosis. Occasionally, tumor arising from the tuberculum, selae, or olfactory groove may invade the orbit through the superior orbital fissure or the optic canal. So basically, in a bony invasion, like the bone is also invaded in the case of orbit. For example, in case of the intracranial meningioma, which arises from the sphenoid ridge, can invade the orbit. And other are like tuberculum, sela, these are also bone, and olfactory groove, these are also bone, and they also invade the orbit through the superior orbital fissure or optic canal. Next is a fibrous dysplasia. Fibrous dysplasia is a disorder in which the fibrous tissue develop instead of normal bone, leading to the weakening and a mass effect, usually in the childhood or early adulthood. Within the orbital region, this may cause the facial asymmetry, proptosis, dystocia, and visual loss. Most orbital diseases due to the monostotic form. Polyostotic disease is associated with endocrine disorder and cutaneous pigmentation, McCune-Albright syndrome. 10% of the cases. So basically, fibrous dysplasia is when the bone is not developed into bone, rather into a fibrous tissue. So it will lead to the weakening and a mass effect. And in the orbit region, if it is present, it can cause the facial asymmetry, proptosis, and dystopia. So there are two kinds. They can be monostotic and polystotic. The polystotic disease is also associated with endocrine disorder and cutaneous pigmentation, and it is known as McCune-Albright syndrome. So this is the fibrous dysplasia of the orbit. A is showing the coronal CT, showing involvement of the floor and medial wall of the right orbit. So this is the floor and medial wall of the right orbit is involved, and B is showing the upward dystopia of the right eye. Next is the orbital invasion from the eyelid conjunctiva and intraocular tumor. Orbital invasion may occur from the eyelid malignancy such as basal cell carcinoma, squamous cell carcinoma, or sebaceous gland carcinoma, from the conjunctival tumor, melanoma, and from intraocular tumors such as choroidal melanoma or retinoblastoma. So these other structures which are the carcinoma of these structure can also invade the orbit as well. So orbital invasion by conjunctival melanoma, B is showing orbital invasion by retinoblastoma. Next is an anophthalmic socket. Anophthalmic socket is basically when you remove the eyeball from the eye. So surgical procedure, removal of an eye and the contents of the orbit may be indicated for an intraorbital or orbital intraocular or orbital malignancy, and or where that eye is blind and painful or unsightly. A number of different surgical and rehabilitation techniques are available. Enucleation is a removal of a globe is indicated in the following circumstances. Primary intraocular malignancy, where the other treatment modalities are not appropriate, the tumor is left intact with an eye for histopathological examination, for example retinoblastoma. After severe trauma, where there is a risk of the sympathetic ophthalmicus may outweigh any prospect of visual recovery, blind, painful, or unsightly eye can also be managed by enucleation, although evisceration is generally considered the procedure of choice. So we have three types of procedure to remove the eyeball. So one is basically enucleation, and other is evisceration, and other is exciseration. So enucleation is evisceration. First we will discuss. So this is an eye globe. So in the evisceration, we remove the cornea and we remove all the intraocular content, and then we after removing the intraocular or uveal content, we close we put the implant and close the rest of the scleral tissue. But in case of the enucleation, we remove all the sclera and the cornea. In case of exciseration, we remove the surrounding orbital structure like muscles as well, and this is called the exciseration, and sometimes bone is also removed in the exciseration. So basically enucleation is performed in a case of intraocular tumors and when there is a risk after the traumatic eye and there is a loss of there is no visual recovery. Evisceration refers to the removal of the entire content of the globe while the sclera and extraocular muscles remain intact. So in this case, we just remove the cornea and then we remove the intraocular content, and then we suture the rest of the sclera. Generally, the cornea is removed to provide the access to the ocular content. Retention of the sclera and lack of disruption of the extraocular muscle provide better motility than is achieved after enucleation. Evisceration provides disrupted and incomplete material for histology and should not be undertaken in the presence of the suspected intraocular malignancy. Next is the exciseration. Excentralization involves the removal of the globe together with the soft tissue of the orbit. Indication include orbital malignancies, either primary or where the tumor has invaded the orbit from the eyelids, conjunctiva, globe, or exudaxa, where other forms of treatment have a poor chance of success. Interiorly sited tumor may allow relative sparing of the posterior orbital tissue, and posterior tumor may allow the sparing of the eyelid skin to line the socket. Following excentralization, prosthesis can be attached to the surrounding skin with adhesive mounted on glasses or secured with the osseointegrated magnets mounted on the orbital rim bones. The socket may be lined with the skin or split skin graft or left to heal by secondary induction. Non-malignant disease such as orbital mucormycosis is a rare indication of an excentralization. So basically, what do? You know that these are the eyelids, and behind this is an eyeball. So if the mass is interiorly located, you will remove the tumor along with the interior portion, whereas if the tumor is located posteriorly, you may spare the eyelids. But after removing the the structure and the soft tissue, you may put the prosthesis, which with the to the surrounding skins with adhesive materials, or you can also use adhesive that can be mounted on glasses or can be secured with the osteo integrated magnets. Or it can also, if there are lots of eyelid or skin is removed, you can also use the skin or the split skin graft. For example, this is a 4.51. This is a removal of the evisceration. You know that a cornea is removed and there is a sclera, and the rest of the sclera is sutured. So this is showing excentralization. It is showing the including eyeball removal. You know that the eyelids are also removed in this case. 2 days post-operatively, patient in a 6 month later with the sparing of eyelids. And in this case, the eyelid is spared and rest of the tissue is eyeball is removed. So how will you rehabilitate the patient after removing the eyeball of the patient? So there are certain techniques that depend upon it. So you know, this is a healed excentralization, and this is the prosthesis that is attached to glasses, and this is a right post enucleation socket syndrome we will discuss, and this is a extruding orbital implant. So next is a cosmetic shell. A cosmetic shell is an ocular prosthesis that is used to cover the thicicle or an unsightly eye. The shell can restore the volume and often provide a good cosmetic appearance with a reasonable motility as a result of the transmitted movement of the globe. So you know, you have might have seen different kinds of shell, or you can say the artificial eye, in which you put into the furnaces, so it give the good appearance of the thicicle or unsightly eye. And when there is an evisceration, you can there is a little mobility as well. So what is an orbital implant? You know, when you remove the cosmetic shells cannot perform very well if there is a lot of volume deficit. For example, if you remove whole of the eyeball, so the eye will have lot of volume deficiency. So to replace this volume deficiency, you replace a silicone or any other material implant into the eye, like a globe. So what it will do, it can also fit the prosthesis as well, and it can also give the volume to the globe. And especially in a case of pediatric children, it can give the bones to adequate volume to grow. So orbital implants, enucleation or evisceration, lead to a reduction in the volume of the orbital content. A large prosthetic eye without an underlying orbital implant does not provide a satisfactory solution due to stretching of the lower lid under its weight. or due to poor mobility. An implant is usually inserted during the surgery at which the eye is removed, though secondary placement can be performed later or a previously inserted implants exchanged. So usually the implant is placed during the removal of the eye, but sometimes it can also be placed secondarily. Implants material can be maybe solid, non-integrated, for example silicone or acrylic, or porous, integrated, polyethylene and hydroxyapatite. So there are two types of material. Number one is solid, another one is porous. The porous one is integrated, which consists of the polyethylene, and hydroxyapatite, which is solid, consists of the silicone and acrylics. The fibrovascular ingrowth into the later facilitate motility of an overlying prosthesis. A peg can also be inserted into the porous material to improve the later motility, or the peg must be covered in situ by socket tissue and cannot attach directly to the overlying prosthesis. The motility of an unpacked implants is also usually good, particularly if donor sclera or mesh rib is used and the extraocular muscle secured to the surface. So a peg is basically when you take the implant and you want the prosthesis to move, you place a peg. Basically it is placed when the tissue is fibrosed and there is enough of the fibrovascular tissue. So you place the peg, and before it, when you place the prosthesis, it gives it a greater mobility. Post-enucleation socket syndrome. So post-enucleation socket syndrome is basically a syndrome which occurs when you remove the eye globe, and there are certain changes that occur in the eyelids which may cause this type of syndrome. For example, there can be ptosis in this, there can be discharge as well, there can be the entropion as well, and there can be the deep sulci as well. So post-enucleation socket syndrome is caused by the failure to collect the volume deficient adequately. It is characterized by the deep upper lid sulcus, ptosis, anophthalmos, and backward rotation of the top of the prosthesis. Extrusion is a significant concern with all the implants. Careful placement of an implant, ensuring it is sufficiently deep and is well covered with vascular tissue, is more important than the choice of the implant material. So basically these are all the complications after the implants. So there can be the post enucleation socket syndrome, there can be extrusion of the implant, means the implant is getting out of the eye. Ocular prosthesis after enucleation or evisceration or conformer made up of silicone or acrylic material is placed in to support the conjunctival fornices and remain in place until the socket is fitted with an artificial eye. So conformer is basically a temporary material which is used in the case of after you eviscerate the eye or enucleate and you put the orbital implant. So you put the the prosthesis into the eye so that the conjunctival fornices remain formed, and until there is a placement of the artificial eye. Initial socket impression molds can usually be taken at around 6 to 8 weeks post-operatively, and a temporary artificial eye placed while waiting for a manufacture of a prosthesis shape to fit an individual socket and matched a fallow eye. So figure 4.58. So it is showing conformer in place. Basically this is the artificial basically this is a transparent material that is placed in the eye, and it is a selection of the artificial eye with the respect to the color of the person eye and the other eye with respect to the other eye. So for example, this is a patient with a prosthetic eye. A is showing thus the empty socket and B is showing matching prosthesis in place. So you can see that there is not much of the difference between the both eyes. Next is a craniosynostosis. So basically these are the developmental or congenital disorders. The craniosynostosis are a group of a rare congenital condition in which the abnormally shaped skull result from a premature closure of a skull suture. So you know that there are different skull sutures. like occipital suture, parietal suture. So when there is a premature closure of the skull suture, it causes an abnormal shaped skull. First is a Cruzen syndrome, then there is a Apert syndrome, and then there is a Pfeiffer syndrome. So Cruzen syndrome features a short anterior posterior skull diameter with a mid facial hypoplasia, giving a prominent lower jaw. So there will be the mid facial hypoplasia. So with what will, if there is a hypoplasia, it will cause the prominent jaw. There will be the proptosis due to shallow orbit. So remember, the proptosis is not due to actual proptosis, but it is due to the shallow orbit which is causing the proptosis. And hypertelorism with wide orbital separation are the most conspicuous ocular feature. Vision threatening complication include, so if there is a proptosis, there can be exposure keratopathy, there can be the optic atrophy. Mechanism include chronic papilledema, cerebral hyperperfusion secondary to sleep apnea. There can be the strabismus, V-shaped exotropia, ametropia, and amblyopia can occur, and other ocular associations have been reported. Inheritance is usually autosomal dominant. Allelic variant in the gene FGFR2 is responsible. Next is an Apert syndrome. Apert syndrome is the most severe of the craniosynostosis, oxycephaly, conical skull. There will be the hypoplasia, mid facial hypoplasia with the beaked nose. Very important, beaked nose. The Cruzen syndrome has a prominent jaw. It has a beak syndrome, nose and low satire. So there is a syndactyly and developmental delay 30% may be present. Shallow orbits. Proptosis and hypertelorism are generally less pronounced than Cruzen syndrome, but the same vision threatening complication occur. Inheritance can be autosomal dominant, but in majority of the cases, the condition is sporadic and associated with parental age. As with Cruzen syndrome, it is frequently the result of the mutation in the FGFR2. Pfeiffer syndrome features the facial hypoplasia like in other two and downward slanting palpebral fissure. So important thing is a slanting palpebral fissure. Ocular features are similar to Apert syndrome. Inheritance is autosomal dominant with genetic heterogeneity. So it has a broad big toe. So remember, the Cruzen syndrome have a shallow orbit. There is a hypertelorism. There will be the exotropia V pattern, and the Apert syndrome has a beak nose and syndactyly, and it has a slanting palpebral fissures and the big toe. Remember these just for the knowledge. You must remember these things uh, because it's a difficult things to remember. So that's it for the orbit. So see you in the next lecture series.